Good afternoon. I'm Bob Wachter, Chair of the Department of Medicine. You've arrived at UCSF Department of Medicine Grand Rounds. Let's start with the ground rules. We'll be quick. I think everybody knows these by now. You all know how to work Zoom. If you have questions, put them in the Q&A box. I'll try to get to as many as I can. The session will be recorded and posted in the next couple of days on YouTube. Where our sessions over the last couple of years have gotten more than 4 million views. And if you are interested in closed captioning, it is available through the button on your screen. If you're interested in CME credits, stay on at the end of our session, and there will be a screen that shows you how to claim CME credit. COVID looks like it has peaked in the Bay Area, as it has in much of the country, and hopefully we will see that followed by a fall in hospitalizations. Hospitalizations are actually quite high right now at our hospitals. But every reason to hope that will fall and illnesses will go down and we'll find ourselves in a new normal in the next few weeks. That is our hope, and we will continue to plan monthly COVID grand rounds, usually the first Thursday of every month. But we're going to be turning our attention to many of the other important issues in healthcare, and one of the biggest is going to be the potentially transformative way that technologies are going to change the way we take care of patients. And one of the prime examples of this is in the care of people with diabetes, a disease that hits about 1 in 10 Americans. And one of the leading experts of the interface between diabetes and technology is our own Aaron Neinstein, who has really an extraordinary background that covers the Venn diagram really between technology, informatics, and diabetes. So Aaron is the associate professor in our division of endocrinology at UCSF Health. He's also vice president of digital health for the UCSF Health System and senior director of the UCSF Center for Digital Health Innovation. He has been involved in everything from our ambulatory implementation of Epic to a whole lot of different digital solutions for a variety of issues, including a real focus in the last few years on improving and transforming the digital patient experience and virtual care. He's also been very involved in research and advocacy and was recently appointed to the Federal Health Information Technology Advisory Committee, which advises the federal government on policies and regulations as they relate to IT. And he's been a leader in digital transformation of diabetes care, including co-founding Tidepool, which is a nonprofit that's created open source software to empower people with diabetes. So Aaron has a unique background here, and his talk will focus. It's called The Revolution in Continuous Monitoring for Diabetes, but one of my interests is diabetes in some ways as a test case for how we empower patients and how we use information using new tools to improve the way we deliver care. So it's exciting not only for people with diabetes, but for all of healthcare. And so Aaron, welcome, and thank you for chatting with us today.
Thanks, Bob. It's great to be here, and also great to be talking about an acronym that starts with C but isn't COVID. So we'll talk about CGM for the next 35 minutes, and then looking forward to the dialogue. Bob, is always asking wonderful questions, and I'm really looking forward to the conversation. So I'm going to phrase this as a question, and hopefully we'll bring you some information by the end of this time about is CGM revolutionizing diabetes care? First, my disclosures. I am a consultant to a handful of companies around digital health strategy and technology strategy in the diabetes space. So many of you have probably started to see more information out there in the media, more advertisements, both in print and on television for continuous glucose monitoring. It's football season, it's the playoffs right now. This is from last year's Super Bowl. There actually was an advertisement for a continuous glucose monitor as a Super Bowl advertisement last year. So you can see how CGM is really starting to enter the public consciousness in a new way. And at the same time, we see editorials like this from the American Family Physician Journal saying that CGM in type 2 diabetes is not ready for widespread adoption. So I want to walk you through a little bit, just background primer on what CGM is, how it works, and then we'll kind of progressively ratchet up the difficulty here in terms of thinking about CGM for type 1 diabetes, for people with type 2 on insulin, for people with type 2 not on insulin, and getting all the way to CGM for people without diabetes and the controversy there. We'll start with a case. This is medical grand rounds, so we'll start with a case. This is a patient of mine, an 80-year-old man who's had type 2 diabetes for several decades. His A1C has been between 7.5% and 8.5%. As you can see, he's on glargine insulin, he's on glimepiride, which is a sulfonylurea, and he comes to me time after time saying that he feels dizzy and terrible. And I've kind of suspected for many years that he might have hypoglycemia, and recommended to him that he reduce his insulin dose, but was never able to get him to make the change. So one day he was in clinic and we had some samples of CGM, and we put one on his arm for 14 days to wear and take home. And what you can see here is this is a single day view across the x-axis. We're looking from midnight to midnight. The y-axis is the glucose levels. And so you're looking at his glucose levels from about 4 a.m. here to about 7 p.m. here, with dropout in some of the other data. And if you look at several days worth of data, it's pretty striking and clear. He is hypoglycemic all night, every night, day after day. And if you look at the average summary that the CGM download gives, you can see that same thing. From 3 a.m. to about 10 a.m., hypoglycemia routinely. And if you look at his 14-day averages, we look now as a metric called time in range, which is looking at people's time between 70 and 180. But what I was really focused on here is his time in hypoglycemia, 18%, 9% of the time in severe hypoglycemic range at below 54. And so we talked again about, let's cut back on the glargine dose, let's cut back on your sulfonylurea. Came back 2 months later, and all of a sudden his hypoglycemia drops from 18 to 3%. As you can see, the averages from midnight to midnight, the hypoglycemia has dropped out. And in the day-by-day views, hypoglycemia has gone. And this wasn't a trade-off for more hyperglycemia. He actually had less high glucoses and 89% time in range. And so this gave the patient more visible information to encourage him to make the change in his medication regimen. So same therapeutic recommendation, different results. He was learning from his own data. So CGM, to put it into context, diabetes has been innovating for a century. So now 101 years ago, insulin was first isolated and started use in humans. 50 years ago was the first at-home glucose testing. 30 years ago was the first transmission in France of blood glucose data over a modem. And then about 20 to 25 years ago, the first continuous glucose monitor became available in the United States. And they've pretty much worked the same way since then. So there's an enzyme that sits on a tiny wire sensor underneath the skin. It's glucose oxidase. As it reacts with glucose, it creates an electrical signal. The electrical signal is converted by an algorithm to an estimated glucose level, and that's what's reported out as a continuous glucose reading every couple of minutes to the individual. There are several different options available, and many more in R&D. Some of the primary differentiators between these, there are some, for the most part, we use CGMs where the patient can see the data in real time. There are also more commonly for research studies, there are blinded CGMs so that the patient can't actually see the data and it gets downloaded at the end of 2 weeks. There are also some devices where you actually have to scan the sensor to get the reading, and other devices that are actually reporting out continuously in real time so you can see it on your phone, on your watch, etc. From a cost perspective, so of course this is highly dependent on people's insurance coverage, and so what I'm going to cite here are really ranges for cash prices. Of course, glucose meters and strips are not cheap, and so those can range at even upwards of $100. Now, historically, continuous glucose monitoring was in the range of about $3,000 a year or $250 per month. Abbott came out with a device in 2017 that was pretty transformative because they not only cut the price in half, but they actually started distributing it through pharmacies and people's prescription drug benefits as opposed through durable medical equipment, which has really opened up access for a lot of people. And of course, the other big difference is that with a meter and strips, the more someone tests, the more it costs. And with CGM, you're getting greater information density without increased cost. So here's a little bit about what it looks like to put one on. You have the needle there that comes in and out when the device is inserted into the skin and into the interstitial fluid. And what's left behind is that tiny wire electrode. Push the button, it's on. The adhesive is quite good. People do get skin reactions some percentage of the time, but these are waterproof. They stay on with activities and exercise. So let's talk about type 1 diabetes. And the evidence are abundantly clear. I put some references at the bottom of the slide here. But essentially, the case is closed. CGM leads to lower A1C, less hypoglycemia. People are no longer afraid that they have to wake up in the middle of the night and not have detected a low blood sugar, improves quality of life. Many of us in the field feel this is the greatest advancement since the discovery of insulin in type 1 diabetes, and it is standard of care across all of our professional societies. And the good news is, over the last decade, CGM use skyrocketed, about an 8-fold increase in use in the United States, and estimates are at about 50% of people with type 1 are using it now. But if you change the scale of that graph with the expectation that everyone with type 1 should have CGM, what becomes clear is that half of the people in the US with type 1 do not have CGM. And this is, frankly, at this point, shameful that CGM is not ubiquitous for people with type 1 diabetes. And as is common in many places in the healthcare system, there are significant disparities in use. If we look across different states, one study looked at FQHCs comparing California to Florida, and there was almost a twofold increase in use in California. And they also, within California, not in Florida, saw disparities by race, ethnicity, and education level. Another study looked at young adults across 6 diabetes centers across the country, about half of whom are on public insurance. And again, disparities in use by race and ethnicity level, even after adjusting for things like age, sex, education level, numeracy, and more. Some of the reasons, it's physician prescribing bias. So there is a long-held belief that only people who already have good diabetes control should be getting access to technology, and that's just not the case. Payers continue to erect barriers, lots of documentation requirements. Here's a note I got in my in-basket saying that a payer had denied a CGM and they need documentation proving that someone with type 1 is at risk for low blood sugar. The other really exciting thing that's now happened due to CGM with type 1 diabetes is it has enabled closed loop insulin delivery. So traditionally, if someone is on an insulin pump, which is giving them subcutaneous insulin delivered continuously, and they're using a CGM, they actually have to look at the CGM, see what their blood sugars are, and decide how to adjust their insulin doses all throughout the day and night. And what has now happened over the last 5 years is there are commercially available devices that put an algorithm in between the CGM and the pump, and look what happens. So you can see here on the bottom, these are insulin doses going on and off through the course of the day. This tracing is their CGM tracing. And as in the middle of the night, they're approaching a low blood sugar, they're approaching hypoglycemia, the insulin actually shuts off, avoiding that low blood sugar that might have hit this individual in the morning. The insulin turns back on as it senses the person waking up for the day, having their breakfast, and the insulin rising, and was able, in this case, to keep blood sugars in target range throughout the day. Pretty amazing technology. At the same time, it's not fully autonomous. So much like the self-driving car story, I think of it sort of akin to bumper bowling. It's really helping provide guardrails, keeping people from significant hypo or hyperglycemic events, but the devices are not fully autonomous, and so we're not really quite at a true artificial pancreas just yet. Let's move on from type 1 to type 2 diabetes. And in people who are taking multiple daily injections, the story is much the same. They are also, despite a commonly held myth that people with type 2 don't get hypoglycemia, people with type 2 absolutely get hypoglycemia. And the good news is with CGM, for people taking basal bolus insulin, multiple RCTs and meta-analyses have borne out that A1C is lower in studies with people using CGM as compared to finger sticks, and they get less hypoglycemia. So the verdict for that case is also quite clear. For anyone who's on multiple daily injections, type 1 or type 2 diabetes, yes, CGM has evidence-based benefit. But what about the many millions of people who are just on long-acting insulin alone? There's a great trial published last year called the MOBILE trial. This was 15 centers across the US. These were adults with type 2 diabetes with variable control coming in. They were just on basal insulin, no mealtime. They were randomized 2-to-1 to CGM versus finger sticks. It was an 8-month study, and they were managed in the primary care setting with some insulin titration education along the way. And the findings were pretty striking. So because they received some coaching along the way, the group doing finger sticks, yes, they saw a reduction in A1C, but the A1C reduction was greater in the CGM group. You can see here the curve separating in terms of the cumulative distribution of CGM versus BGM. What was also pretty incredible, so they put those blinded CGMs on all participants. They could actually see granular CGM data even in the group that was just doing finger sticks. And it's so striking as you look at these graphs. The blue are the interquartile ranges throughout the day for people using finger sticks, and the red you can see is much narrower, much flatter, much more in range for the people using CGM. And that was borne out. So there were about 3.5 hours time in range higher per day for the group using CGM. The other thing that was really amazing is at the end of the study, there were no significant differences between the two groups in their medication regimen or in insulin dose. And so the implication there is that the people who were looking at their CGM for 8 months, they learned about their lifestyle choices, they learned about using their insulin differently, and they learned to avoid hypo and hyperglycemia from the CGM. This wasn't the doctors prescribing a different medication regimen that made the difference. The other really compelling thing about the MOBILE trial are the study population that they selected. More than half public insurance, more than half no college degree, more than half non-white, and again, 100% in the primary care setting. So there's a wonderful editorial from Dr. Monica Peek at University of Chicago. If people are interested, I highly recommend reading it. And she really calls out how much Medicare policy in terms of coverage for CGM has contributed to disparities in addition to prescriber bias, and really hits a note here saying the time has come to broaden access to CGM for patients with type 2 diabetes, and I couldn't agree more. So we've covered people who are using insulin. Let's take this one step a little bit more difficult to what about people who have type 2 diabetes who are not on insulin? So many people may remember about a decade ago, the Cochrane Review did a summary essentially saying, if you have type 2 diabetes and you're not on insulin, don't bother with finger sticks. They don't change quality of life. They don't change A1C. And they really don't improve outcomes. And so that dogma has kind of carried forward into CGM. But what I want to argue is that we can't look at CGM as just a better finger stick meter. We just saw cases that showed that CGM is categorically different. And I want to show you another one that I think really tells the story here. This is a 70-year-old man, has type 2. He's not on insulin. He's on metformin and a GLP-1. He doesn't do finger sticks. His A1C is in the low 7s, also has coronary artery disease. And I put a CGM on him for 14 days, and immediately he saw every morning these spikes in his blood sugar, the same humps. You could see the same pattern, and it jumped off the page when I sat down with him and looked at this. And he said, oh yeah, I forgot to tell you, my breakfast every morning is a banana and a couple of glasses of orange juice. That must be what's causing these spikes. And if we looked at his data, and if we had just checked fasting glucose levels, a finger stick every morning, we would have seen that they were all between about 100 and 130. We would have looked at his A1C, and it was close to target range. And we never would have had the opportunity to have that conversation that he was leading. He identified it as he looked at his CGM data, that the breakfast foods that he was choosing were having those impacts on his blood sugar. It was plain there for him to see. All of you can recognize this, I hope, as a telephone. We also call this thing a telephone. And yet, when we have analog devices, with the example of the telephone, all it does is make phone calls. And when the iPhone came out 15 years ago, it opened up a new world because it was a digital phone. It was a computer in your pocket. And so because it was connected to the internet, you could surf the web. And then a year later, they came out with the App Store, and all of a sudden, everything was connected to social media. You could do shopping on your phone and many other applications. And the point is that when you digitize something, it's no longer the same thing. And I think the same thing is true of CGM. Again, it's more than just a better glucose meter. And as Bob intimated at the beginning, I think we're going to see, as we have connected data to the cloud, and there's going to be an opportunity to develop tons of new applications using the CGM data to transform care. So going back to the question of, well, what about people with type 2 who are not on insulin? Is there benefit? We have low quality evidence to suggest that there may be benefit. So there are a few retrospective, large observational data sets that are taken from large publicly available data sets that show a reduction in A1C. This is just looking 12 months after someone got a prescription, and A1Cs are lower, low quality evidence. There's one small randomized controlled trial that was published in 2020. They took 30 people, they randomized them to routine care or CGM with coaching. And what they saw is no change in A1C in the routine care group. In the group that got CGM plus coaching, a 1.3% A1C reduction. And in this case, more behavior change, fewer diabetes medications, less carbohydrate consumption, and improved empowerment, knowledge, and quality of life. So I think more research is needed in this area, but there are some studies suggesting that there's probably a benefit to people not on insulin. So let's zoom out again. I said that CGM is categorically different than BGM when it comes to being a device that is digital and internet connected. So now this is a look at a dashboard we can access in our diabetes clinics with hundreds of people continuously connected, where their CGM is streaming data to the cloud 24/7, 365. And we can actually sort across our entire clinic population who of our patients have the most hypoglycemia. Who are the people at the most significant risk for an ER visit or a dangerous outcome from hypoglycemia? And then you could imagine, well, if we can sort by who is at risk, what if we build proactive outreach and communications rather than waiting for people to have a scheduled office visit every 3 months? What if we started more dynamically reaching out to people and triaging them based on who is at the greatest risk and who has the most need for an intervention at any given point in time? It also completely changes the way that the doctor-patient interaction happens. And I want to share with you a 40-second video here with great thanks to Allison for allowing me to share this. And I have a few words to say about it at the end of the video.
Like if I'm 70 and I'm going to eat 15 grams and my pump says, don't take 1 unit, take 0.7. Like there's a part of me that's like, nope, I'm going to take the whole unit still. Mm-hmm. David, I made cookies for Nick's birthday. Oh. And I like cookie dough. And so I was trying to be like, okay, it's okay that my blood sugar is going to be high.
Uh-huh. So again, sort of like big picture here. So this was a splurge day, and you were up out of range for like 45 minutes.
At 3 o'clock, I'm kind of usually going down. I was going to just bring my basal rate down. It's at 0.4 from 12 p.m. to 3 p.m. I was going to bring it down to like 0.35.
So a few things I think are striking from that conversation. So one, the EHR is looming in the background. And here we are, we're using software, looking at her CGM and her insulin pump data, and we're using her device data, and she's driving the conversation. She's taking me through it. I'm there as her coach, as her guide to provide support, but armed with the power of more information and data, she's really driving the conversation. And it's no surprise that because of the ability to leverage technologies like CGM, that these data are now about a year and a half old, but this is from fall 2020. Endocrinology was one of the top specialties across the country in use of telehealth, just behind, or quite far behind, mental and behavioral health, but ahead of other medical specialties. And as we think about modern care delivery models, the opportunity is, how can we use, again, more population monitoring and targeted interventions at the people who need care when they need it, and move away from a model where our most expensive part of our care delivery system, our doctors, our nurses, our physical clinics, where those become more the exception rather than the rule, and we start with more targeted consumer-oriented interventions and reaching out to people, texting them, and then bring them into clinic when they need it. And so this is hard to retrofit our traditional care delivery system to that kind of a model, but there are many companies that are building virtual diabetes clinics from the ground up. So here's some data that one of them, this is a company called Onduo, they reported on their data after a couple of years of launching. They send CGMs out to people, and they have an app where a coach interacts with people leveraging their CGM data. They showed A1C reductions in all categories other than the people who started with A1Cs under 8%. And this held true both for people using insulin in their population, as well as non-insulin users had reductions in A1C with this combination of CGM and virtual coaching. And the fact of the matter is, as Bob was saying at the beginning, transformation is needed. We're not doing well with diabetes in our country and how we help manage it. Almost 10% of Americans have diabetes. Prevalence is rising. It's very expensive to our healthcare system. And we continue to have almost 250,000 each per year, people coming to the ER for either hypoglycemia or hyperglycemic crises. And so there were a couple of papers published recently looking more at an economics view and a healthcare utilization view around CGM, both from integrated delivery systems. So one from Intermountain, this was a smaller cohort of 113 patients. They showed similar effect size here, 0.6% A1C reduction with CGM, decreased utilization of services, fewer ER visits, fewer labs, and a reduced per member per month cost. Kaiser took a similar cohort. There were about 6,000 people using CGM, mostly type 1 diabetes, but there were some with type 2 diabetes in their cohort. Again, lower A1C, fewer ER visits and hospitalizations for hypoglycemia. In the Kaiser cohort, they didn't actually see a change in overall utilization. So let's get to the really controversial stuff. What about people without diabetes? So we know from 20 years ago, the diabetes prevention program really showed that through a structured lifestyle intervention program with exercise coaching, dietary coaching, that you could reduce the progression from prediabetes to type 2 diabetes. The problem was that attrition rates were high. It was very difficult to get people to enroll. And so about 10 years ago, Omada was one of the first companies. Now there are others who said, what if we try to make it easier for people to access the diabetes prevention program, and we just deliver the traditional diabetes prevention program through the internet. And they are in the process of publishing their data showing some of their initial results. Now what's happened is as CGM has become more accessible, and we've seen more and more consumerization in healthcare and a move towards digital health, is there are now a slew of companies who've said, what if we give CGM to people who look like this, who are athletes and healthy, and promise them that anybody could improve their health by using CGM? And I think this is a really slippery slope, and I'll come back to talk more about this at the end. There's one school of thought that says, well, if you don't have diabetes, here they gave about 120 people CGMs that were not diagnosed with diabetes, and really 96% of the time, on average, they had normal glucose levels, and only 1 or 2% of the time did they veer a little bit high or a little bit low. But I think this is a case where the averages are misleading. And what do we really mean when we say a person without diabetes? Because type 2 diabetes is very heterogeneous. There are many different genetic underpinnings to type 2 diabetes. There are many different phenotypes in terms of a mix of people having liver pathology, or muscle or fat tissue pathology, or pancreatic pathology. And we think that it's a very heterogeneous definition for what is probably an underlying group of heterogeneous disorders. And the risk we know is continuous, not binary, right? So we draw these categorizations and we say, when your A1C is 5.6, you're healthy, and all of a sudden your A1C is 5.7, and now you have prediabetes. And we know that it's not a binary risk, that it's a continuous risk, and we've decided where we think treatment confers a greater benefit than harm based on where you are on your risk for progression to diabetes complications. And if you look closely, so if you give CGM and you don't just take the averages, but if you look at the tracing, compared healthy people to people with prediabetes to people with type 2 diabetes, it's pretty obvious that the variability and the signatures there are quite different. There was a very interesting body of work done by a team of researchers at Stanford. They took 57 healthy people who didn't have diabetes diagnosed by traditional metrics, who put them on CGM, and they actually used machine learning. They took 2.5-hour windows of time, and they used machine learning to characterize the different sections on their CGM tracing. And they said, well, this is low variability, this is moderate variability, and this is severe variability. And they created what they called glucotypes, which are these clinical metabolic phenotypes based on people who fall into one of those three categories a predominant amount of time. And they did show that these categories were very well correlated to measures like glucose tolerance tests, insulin resistance, and other clinical measures. But what was really striking when they looked at their data is that 25% of people who didn't have diabetes by traditional definitions fell into the category of severe glucose variability or a severe glucotype. And so I think this really begs the question, now that we have access to CGM and we're not using just finger sticks that give you one random data point, and we're not just using A1C that's an average, could looking at CGM-derived glucotype actually give us a different type of risk stratification or an earlier risk stratification to predict people who are going to have downstream bad outcomes? And could it actually better characterize phenotype, whether people have a predominant issue that is more insulin production versus insulin resistance, based on the signatures in CGM patterns? And this was only with 57 participants. So imagine if you start applying this to hundreds or thousands of people who are considered healthy or have family history or a history of gestational diabetes, to give a better sense of their glucotypes. Of course, this being Stanford, they created a company, and they've just published results from the first couple, the first cohort of people who used CGM with the predictions and the machine learning around the CGM tracings and glucotypes. And so they're reporting, it's a 10-day study period, so they didn't look longitudinally, they just looked at the 2 days at the start of people using CGM plus coaching and the final 2 days of people using CGM plus coaching. They had a heterogeneous mix of people with type 2 prediabetes or no pre-existing known diagnosis, and again, gave them a 10-day CGM plus a personalized coaching regimen. And so to ask the question of can CGM improve outcomes for people without diabetes, here's our first sliver of a look at time in range. So that time between, in this case, they looked at 54 to 180, even for people with no pre-existing diabetes diagnosis, was improved. And so I'll come back to the diabetes prevention program. So could CGM actually enable a more modern diabetes prevention program? So instead of a structured one-size-fits-all curriculum, could we actually better risk stratify people and create programs that are more personalized and more targeted at an individual risk of preventing complications? So a few closing thoughts. So we've seen some cases and we've seen some studies that suggest that CGM is probably effective to drive behavior change. There are some big questions that are still out there. So first is, as we look at the glucotypes, do those actually predict long-term complications? Because ultimately that's what we care about. We don't particularly care about your glucose. It's the glucose as it relates to cardiovascular outcomes and microvascular disease. And we don't know if these personalized signatures correlate to those long-term outcomes. We also don't know, in particular for the lower risk population, how safe is CGM as a biofeedback tool? So I talked about these companies who are giving CGM to young, healthy people. Well, what happens if you're optimizing for a single physiologic parameter, a single variable, glucose, you could theoretically eat bacon all day, keep your glucose low, but are you making yourself healthier? So I think we really need to understand what happens when we optimize for a single variable, in particular in those lower risk populations. We have no idea what the right dose is. So we don't know if using a CGM once a year, once a quarter, or all the time are needed. So what's the dosing of CGM that's required to affect a change? And then can you use CGM alone, or does it need to be accompanied by coaching? Most trials tend to combine those things together, and I'd love to see those teased apart to really understand what is needed. And then depending on the risk and cost of a particular segment of the population, is it cost effective to use CGM? So it could be that for people with A1Cs of 5.6, that CGM is really effective, but is it cost effective? And depending on where people fall on that risk spectrum, there probably will be different cost effectiveness seen. So net, for all the people out there who are practicing medicine and are not endocrinologists, which is the majority of you, really encourage you, for anyone who's on insulin, whether that's type 1 or type 2, try to help your patient get a CGM. Now, for people who have type 2 or prediabetes, where they're somewhere on that spectrum, who are not on insulin, I would consider using CGM to enable self-learning and some lifestyle feedback if the patient is interested. I tend to offer it to people if they're interested. I encourage them to treat it like a science experiment, to try different foods, try different activities, and see what happens and see what self-learning they can get out of it. If you're looking for references or a guidebook on how to interpret CGM data, here's 2 great references which give you kind of a step-by-step breakdown of how to look at CGM data and how to interpret it. So coming back to the big question, so is CGM revolutionizing diabetes care? So unequivocally, for people on insulin, yes, CGM has already revolutionized care, improved quality of life dramatically, including getting rid of a lot of fear of hypoglycemia for people who are using insulin. For people with type 2 who are not on insulin, I think CGM is revolutionary as a biofeedback tool. We saw a few cases here where people are learning as they're seeing their data, and it allows them to interpret it in a way that is so powerful and so different than other things that we can offer them, and really catalyzes conversation. So rather than us talking generically about a healthy diet, it's personalized, that the person can see what's happening based on what they're doing, and enables them to learn and drive the learning. Of course, just like the iPhone revolutionized what it meant to be a phone, when you digitize glucose monitoring, it means it's connected to the cloud, it's connected to the internet. It allows this whole new ecosystem to emerge of digital clinics that are leveraging CGM data to change the care model and experiment with different care models that weren't possible before. And my hope is that they resist the huge financial opportunity and the allure of catering to the worried well. And there's so many people already in the United States who have family history, who have prediabetes, who have type 2, who really need improved coaching. And I really hope that the startup community focuses on them. No matter what happens, I think we're going to learn a lot. We're going to learn, this is the first time that so many people are wearing continuous glucose monitoring, and we're going to learn about phenotypes and risk categorization. And these companies are going to be experimenting and driving learnings and coaching and lifestyle modification. And I think the real question here is CGM revolutionizing diabetes care? Because it is. But is this a window into the transformation in healthcare overall? And so across other medical conditions, everyone out there has different medical specialties. Think about in your own specialty, what it looks like to have your own CGM. What happens when you have continuous data so that your clinic can do population monitoring, leveraging continuous biometric device data? What does it look like when you have a continuous biometric device that's capturing data and allows new phenotypic understandings, new diagnostic and risk stratifications? And then what does it mean to actually personalize our treatment plans? We've talked a lot about precision medicine over the years. And so not only could we have more precision diagnostics, but what about more personalized precision therapeutics that based on an individual's needs and what's going on in their lives, that we tailor the coaching and support plan to that individual. So with that, I am going to stop, and I guess we'll bring back Bob.
Thank you, Aaron. That was fabulous and eye-opening, and I particularly enjoyed the last part because to me that is the big question of sort of what this leads to for other disease states. So got a bunch of questions. Let me start with a few of my own. Just this is foundational, and you sort of presented this as if it's true, but let's just be sure everybody understands it. You made the point that hemoglobin A1C is a proxy, particularly for pre-diabetes or people checking it. But in people with established diabetes, is it fully established that if I can bring your hemoglobin A1C from 8 to 7, that your chances of bad outcomes are lowered?
Yeah, those data are unequivocal. So they're now decades old, but there were 2 large trials, the UK PDS in type 2 diabetes and the DCCT, or the Diabetes Control and Complications trial, that were, I think, published both in the early 90s, which proved they were large randomized control trials, which you could never get funded again today, that certainly proved that tighter diabetes control, lower A1C, is associated with better reduced risk of microvascular complications. The same did not always hold true for cardiovascular. That's a different story there. But for microvascular disease, there's no question.
Great. A couple technical questions. So you mentioned that these were bumpers rather than it bowling for you, and that it's not fully autonomous. Why not? What are the obstacles to? You'd think that this is almost an easy one, sort of a completely closed loop, a measure, an algorithm, a change, a measure of the change, and what's the obstacle to making that a closed loop and actually making it a single device as opposed to 2 devices that have to integrate?
There are several. So some of them are hardware challenges, making sure that the CGM can stay on properly and be working properly all the time. The insulin pump infusion sets, they have some challenges. Sometimes they clog, the tubing kinks, and so people can get bumped out of closed loop. The other thing is that insulin itself, we think about, I think oftentimes people have this fantasy that an insulin pump, because it's delivering insulin all the time, that the insulin works fast, but actually it's still going subcutaneously. And so the absorption of insulin and its bioavailability are still just like injecting subcutaneous insulin. And so it's almost like flying a plane where the dashboard is on a 30-minute delay, and then when you turn the plane or you change the altitude, that's also on a 30-minute delay. And so it's a little bit more challenging than people realize because the feedback loops are not super tight. So I think of it's very similar to the self-driving car world, where we went from cruise control to adaptive cruise control to almost self-driving. We're kind of seeing that same progression happening, where the systems are getting more and more autonomous. The other thing is that there's some research going on as to whether systems should have dual hormone, whether they should use glucagon, so that you can kind of push insulin, and if you go too far, rather than just stopping insulin, you can actually give glucagon as kind of a rescue to bring the blood sugar back up. But none of those have really become commercially available. They're all still in research trials. So I think they're going to get better and smarter over the next few years. They'll start, right now, they're kind of dumb systems where they're not adapting to behavior. For women, menstrual cycles change, glucose response and insulin response every month, and the systems just don't have that information today. I think in the next 5 years, they'll get much better.
Can you imagine a world where they're understanding your level of activity, and obviously they can pick up how much you're walking and all that, and somehow those issues sort of get integrated into the decision making?
Yeah, absolutely. There's no reason, more and more people are wearing wearables that measure their heart rate. There will be more variables and vital signs available. always the hardest one and the biggest variable is food. Current systems, people still have to estimate their carbohydrates and put them in. There is a community of hackers who are really amazing, who create open source software for closed loop insulin delivery systems. And they've actually developed some algorithms that ignore food, and the system can kind of help manage it even without knowing exactly how much food you've eaten, which for anyone with type 1 diabetes, of course, would be a godsend because they would love to not have to count carbohydrates. I think we're still several years from those being commercially available also.
Right. There are a number of questions around the insurance coverage and the hassle factor in getting this for your patients. So just describe where this is, where it's come from over the last few years, what kind of progress has been made, and the differences in trying to get one of these for type 1 versus type 2 versus prediabetes.
Yeah, for type 1, insurance coverage is pretty much universal now. The documentation requirements are not necessarily easy, and of course they're very variable in terms of whoever's interpreting the documentation, but coverage is pretty much universal for type 1 diabetes. For type 2, it's much more of a mixed bag. Of course, everyone looks at what Medicare is doing. Medicare's criteria include someone has to be on 4 shots of insulin per day or more. And thankfully, they just eliminated, in large part due to a lot of the advocacy work that I was mentioning earlier, there used to be a requirement by Medicare that you had to do 4 finger sticks per day to qualify for CGM, which of course is completely counterintuitive because finger sticks are awful. Medicare doesn't even pay for enough test strips. And so they were forcing you to jump through this hoop in order to qualify. They've just done away with that requirement. So pretty much if anyone's on 4 shots a day of insulin, whether type 1 or type 2, on most plans now, they qualify. Coverage for people not on insulin is definitely spottier. Some commercial plans will do it. Coverage for people on 1 shot a day of insulin, Medicare is not there yet, but that's where there's a lot of advocacy from the diabetes community, from the ADA, really trying to push Medicare on this issue and get them to start covering it.
Carl Grenfeld wanted to know, how are you dealing with cognitively impaired patients put on CGM who don't fully understand it and might make mistakes in using it?
The same thing is true. I mean, it's cognitively impaired people using insulin is just challenging no matter what. And so I think the same thing is true whether they're on finger sticks or CGM. What CGM affords the opportunity, though, is that a loved one can follow from home. So you can set up a follow app now with most of the CGM makers where a caregiver or a loved one, or this is huge in the pediatrics community, a parent of a kid at school with type 1 can now actually see the CGM in real time. So I think insulin management in that community is difficult no matter what. I think CGM makes it better.
Great. Someone asked about use in pregnancy.
CGM is approved for use in pregnancy. There are a few, so historically some of the CGMs had lower performance if people are taking high doses of vitamin C or Tylenol. So there are a few caveats to use, but in general, the companies have gotten pretty good at blocking out those substances. It is effective in women who are pregnant. And I think as we think about other populations, chronic kidney disease is a huge population especially where A1C we know has limitations, and A1C might not be very accurate in certain populations. CGM can be incredibly helpful in those other populations. So absolutely yes for pregnant women.
Another population someone asked about is use in hospitalized patients. I think we're still doing finger sticks in the hospital, right?
Great question. So actually, amidst the pandemic emergency, and I think this started in New York, there was a waiver from the FDA that said, because nurses were stretched so thin, the care teams didn't think about how many times a day nurses go into patient rooms to measure blood sugar. And imagine that in the midst of a pandemic, the strain that was putting on hospitals. So the FDA actually gave a waiver 2 hospitals across the country allowing inpatient hospital use of CGM. And so many hospitals took advantage of that opportunity. It's unclear how long that waiver, I think it's still active. It's unclear how long that's going to be good for. Actually, one of the hospitals just published the first paper looking at paired comparisons of finger sticks to CGM, and it showed the CGM in a hospital, these were non-ICU patients, were relatively accurate. I think it's only a matter of time before it becomes standard of care, but there's a lot of challenges around workflows. Finger sticks are very baked into day-to-day care processes and operating workflows. Using CGM would be a very new thing for staff. And I think more data are needed on accuracy, especially as you get into the more sort of sick ICU patients who are edematous. It's unclear whether CGM is accurate in some of those populations.
Got it. So speaking of workflows and overwhelmingness, I have to say that when you said it's not just the patients using it to monitor themselves, but now it's flowing into the clinic and everybody's happy to have these data to help manage their patients. There's my little BS detector went off slightly and said, really? They're trying to see patients every 15 minutes and now all these data are flowing in and you're worried that if you miss something terrible is going to happen, you get sued. And so tell me, in real life, how does the workflow work as this kind of data now flows into a clinic that really wasn't established to have continuous data flowing in?
I think that last thing you said is a really important point, which is we weren't built for this. So the traditional healthcare system in diabetes was built around come in every 3 months, get an A1C done, schedule an office visit. And so to clinics that were built around that care model, this does look and feel like extra work that we don't have staff for. Now, fortunately, there are billing codes, fee-for-service billing codes for CGM. So there is reimbursement as a procedure for CGM review. But I don't think that long-term that's the answer. And this is where all of these new companies are popping up, where they say, this isn't extra work, this is the work. The work actually is to monitor the population. If you change the question, if you have CGM data streaming in and everybody connected, rather than defaulting to these every 3-month office visits, let's work the most acute 10 people every day, get them in for care and phone calls and visits. So when you flip that care model, I think it opens up an entirely different set of opportunities. I think in the traditional delivery system, it is going to be a challenge. I think one of the things that is going to have to be more well developed than it is today is the machine learning and the better both intelligence and filtering into actually filtering out the white noise and knowing who actually needs an intervention, and maybe even some more automated triage and reach out, where if that panel of people most at risk are identified, maybe the first thing isn't a phone call or the doctor, but maybe there's a text message that goes out to check with the patient and do some initial triage before it gets to our more expensive staff.
So do you envision that, let's take your own clinic, do you envision that a clinic like yours, that eventually UCSF sort of contracts with a company that provides a CGM and provides the first layer of monitoring and the AI and handles 89% of the problems, and the 11% that are appropriate to see your clinic then get through to you? Or do you think we end up building such a thing?
I think it's probably more the former, especially as we start shifting our mindset from it being our responsibility just to care for the person sitting in front of us in the office. We're thinking more like a integrated delivery network now. So as we take more responsibility for the population of people who either have diabetes or at high risk for diabetes, we don't have the bandwidth to be directly caring for all of those people. And so I think we're going to have to be more judicious with really people with type 1 diabetes or people who are having a lot of hypoglycemia, being the ones who are more likely to get office visits with a doctor and use another layer of care for the majority of people, whether that be one of these potential partner companies that are built to do continuous coaching and monitoring.
Yeah, it seems that way to me as well. I just gave you an example of why it might be exhausting for clinicians. You ever find it's exhausting for patients who are used to just seeing these numbers 4 times a day and now theoretically have some responsibility and feel an obligation to be looking at it kind of all the time? Or maybe the fact that it's bumpers, it's filtering enough so they're really not being provoked to obsess about it.
It definitely happens. The systems do alarm, and so just like doctors and nurses in the ICU, patients get alert and alarm fatigue from the system alarming all of the time. So people do take vacations. We encourage people to take breaks or vacations from the devices. I think so. Yes, absolutely, it happens. I think there's still a net positive, but alert fatigue does happen.
Right. Yeah, it's been really a tough issue. Probably might be the last question because it's a hard and long question in a way. It sort of gets at your last point. So in some ways, diabetes is a special case of a given physiologic parameter that changes every second, that we know that getting it better managed has health benefits in all directions. So the question is, what else is like that? As you were talking, I sort of thought of the analogy of continuous EKG monitoring, which is revolutionizing cardiology in a way, whether it's through your Apple Watch or through one of the patches that stays on for a month at a time. But you can imagine a world where it's just as easy and maybe it doesn't even require a needle to measure your sodium and your creatinine and your oxygen and your microbiome, for all I know. So, and your immune, the status of your immune system and whatever it is. So maybe spool that out a little bit for us. As the monitoring gets better, where does something like this work? And do you think you end up having one monitor that's just monitoring 100 different parameters? Or are you wearing 5 of these? Or, just how is this going to play out with other disease states? Strikes me diabetes and maybe your heart monitor are sort of the 2 almost easiest examples.
I think you're right. I think there's a short-term answer and there's a longer-term answer. I think in the short term, there are a handful of conditions that have similar opportunities, lung disease being one that's most prominent. So home spirometry measurement, huge opportunity for people with asthma, COPD. We've got a great program going at UCSF with our lung transplant program, where we're now monitoring people across the Western United States using home spirometry. So I think that's one example that comes to mind. There actually is some evidence that using heart rate for people with thyroid disease might actually allow diagnostic and therapeutic precision. So I actually think there's some opportunities using the same sensors for different use cases. There might be other potential conditions where that becomes true. So I think those are the first few that jump to mind kind of as the short-term opportunity. And then, of course, as you said, the companies are building better and better sensors to measure more and more things. So I do think we will start to see more of this across different conditions over time. And I think the opportunities will be limited by science and by our creativity. Because I think the heart rate and the thyroid disease is a great example. Everybody thinks about continuous heart rate monitoring and its application to cardiovascular disease, but it turns out you can see people with Graves' disease go into thyrotoxicosis or go into remission looking at their heart rate data. It's pretty compelling and interesting. So I do think there's sort of those adjacent opportunities that may present themselves the more and more sensors that are available.
Yeah, it is a little bit mind-blowing when you think about that as the measures improve, what will the use cases be and what does that feedback loop look like for other disorders? Well, I really appreciate you presenting this, and you have a unique role in that you think deeply about the diabetes portion of it, but by virtue of what you do in the informatics world, you're thinking about these other states, which is really extraordinarily valuable. So thank you so much. It was terrific, and we'll see you back again next week. Thanks so much.